Okay, good morning, everyone. Again, a fresh Monday. We are starting with a very new topic, very important topic, how to handle a patient with dementia as a palliative care physician. And this topic will be taken by Dr. Manisha. Manisha is our post MD. She has almost finished. Now she is almost finishing her senior residency also after finishing 3 years of MD palliative medicine. Now she is finishing 3 years of residency as well. And moderator will be Dr. Nishkarsh, bright professor of our department, and take active initiative of in all the departmental affair which is wherever required. So I'm sure that Manisha and Nishkarsh together will uh, give you very good insight about this topic. What exactly a palliative care responsibility or palliative care physician's role in a patient with dementia. So go ahead with the Manisha. Manisha and Nishkarsh, please go ahead.
Thank you, ma'am.
Thank you, ma'am. So, uh, dementia is something which is very important topic to discuss because this can be really debilitating for elderly patients, and incidence is quite common. So, we'll be discussing about dementia, basic pathophysiology, what are the differential diagnoses we need to keep in mind, and then how do we plan palliative care symptom management and end of life for these patients. Manisha, please start.
Thank you, sir. So, today's topic is palliative care in patients with dementia. Why this topic is important? Because all of us would have witnessed one or two, some patients, some our near or dear ones with dementia, or you might have missed some case of dementia because of this lack of knowledge regarding how to actually identify dementia. And I'm thankful to Nishkarsh sir for moderating it. So the outline of my seminar will be history, a case scenario, definition, prevalence, what are the types of dementia, evaluation, grading, symptom assessment and management, care burden, caregiver burden, advanced care planning, prognostication, future prospects, and lastly, conclusion. So the history, the dementia arrived from a Latin word demens, which means being out of one's mind. And it has been used since 13th century. In 1906, the first description of Alzheimer's disease was done by Dr. Alois Alzheimer, who examined the brain of a lady called Auguste Dieter, who died after experiencing dementia. And under his microscope, he discovered a buildup proteins, which scientists later went on to symptoms that we would recognize now as dementia. So the common case scenario may be a 65 years old male brought by son. There will be gradual cognitive decline, which had started at 3 years earlier. There will be serious calculation mistakes that will make him to quit his job. There will be frequent forgetfulness, memory impairment, which will hamper him for fulfilling his duties. There will be frequent job change. There will be apraxia and apathy, which would have started some 2 years or 3 years back. There will be, the patient will be disorientation to time and person, which has worsened. They are impossible to commute the daily between his workplace and home. And he always needed a frequent reminder, and he was not able to maintain his personal hygiene. Always there will be sleep disturbance, which will lead to frequent waking up in the middle of the night. The dementia is dementia is an umbrella term for a number of neurological conditions, of which the major symptom is deterioration in the cognitive function, that is, the ability to process thought beyond usual consequences of biological aging. The term dementia was used in DSM-4. However, it has been replaced by a neurocognitive disorder in DSM-5, and it is a major neurocognitive disorder in DSM-5. There is significant cognitive decline from the previous level of functioning. This will interfere with the independence in everyday activities. The disturbances are not occurring exclusively during the course of delirium. And however, we should always rule out the major depressive disorder and schizophrenia in these patients. The most common is the Alzheimer's disease, which accounts for around 60 to 80% of the cases. So the cognitive domain, and as well as the what are the warning signs, the complex attention, which involves the sustained attention, divided attention, and selective attention and information processing speed. However, the warning signs will be there will be increased difficulty in environment with multiple stimuli. Like multiple stimuli, it means the auditory, like radio and all, TV, like the patient is seeing. And they are unable to handle these multiple stimuli together. Executive ability like involves planning, decision making, working memory, and also responding to the feedback, error connection, overriding habits, and mental flexibility. However, in the warning signs can be the patient needs to rely to others to plan his activities of daily living, making decision. They have problems in abstract thinking, and there is loss of initiative as well as poor or decreased judgment. In language, they will be having difficulty in expressive or receptive language. They may not even recall the name of their close friends and family. The perception, motor, and visual perception and praxis can be there. And the patient will be difficulty with the previous familiar activities like driving a motor vehicle or using tools and navigating in familiar environments. The social cognition, which involves the recognition of emotions and behavioral regulation, social appropriateness in terms of dress, grooming, or topics of conversation. The warning signs may be that there will be change in the behavior, like the insensitivity to social standard or making decisions without regard of safety. And they have little insight into these changes. They become socially withdrawn and isolated. Why this is important? Because the prevalence of dementia in India is around 5.3 million in Indians who are more than 60 years of age. And it is projected to exceed by 14 millions by 2050. However, the global prevalence is around 57.4 million cases in 2019, which is going to increase by 152.8 million in 2050. What are the factors which influence the dementia? Firstly, the increasing burden of cardiovascular disease, which may increase to the vascular dementia. The social, economic, and cultural diversity may be there, as it has been found that those initial stage of life, those who have the lower socioeconomic status, they had more chance of dementia because of the poor nutritional status. Genetic diversity may be there because of this. Some apolipoprotein proteins are also associated with dementia. Multilingualism, it has been found that those who know two languages, who can speak in two languages, they have 3 times less chance of having dementia. Low level of literacy are also associated with it. And rural majority with rapid urbanization are also associated with dementia, because so many times, like in rural population, some patients will be initially in the joint family. However, due to the urbanization, they have become the nuclear families. So mostly the older people, they used to live in some joint family. Now they are living in nuclear family. So there's a chance of isolation as compared to before. Also, the malnutrition and low literacy in women are also cause dementia, because in our society, most of the times the women are given less nutrition. They are a kind of abandoned from the they are not given that much importance as compared to the male counterparts. So this may be the cause of dementia prevalence in India. So this was an article which shows that the first one, which shows the life expectancy at birth for the South Asian countries. So we can see here the life expectancy is increasing, and 2050 it's around some 80. It's going to be around 80. However, it's just because the life expectancy is increasing, so the percentage of population who are more than 65 years of age will also increase by around 20% by 2015. So there is a chance of more dementia in the coming years. So the symptom burden is increasing. However, the fertility rate is decreasing, but just because the percentage of population, the population is increasing, so there are more chance of dementia. So what the dementia with the is there any association in cancer patients who have dementia? So this was an article which was published in 2021. In 2021, which shows that there is an association between cancer and dementia in all the cancer entities, like they have taken skin cancer, digestive organs, prostate, breast, urinary tract, lymphoid, and hematopoietic tissue. However, it was more in the lung cancer. So the awareness is important, because the comorbidity in cancer patients, this will increase the comorbidity. These are the types of dementia, the most common types of dementia. First is the Alzheimer's disease. Second one, the frontotemporal dementia, Lewy body dementia, and the vascular dementia. Alzheimer's disease dementia is due to the abnormal deposits of amyloid plaques and the tau tangles throughout the brain. These frontotemporal is due to the abnormal forms of tau and the TDP43 proteins, which accumulate mostly in the frontal and the temporal lobes. And Lewy body dementia is due to the deposition of Lewy bodies. However, the vascular dementia is due to the disruption of blood flow to the brain. Alzheimer's disease occurs mostly in the 60s. Frontotemporal dementia between the 45 to 64. This Lewy body in more than 50 years, and vascular is usually in the 65 years. What are the symptoms the patient have in this dementia? In Alzheimer's disease, mostly the mild will be the wandering and getting lost. There will be repetitive questions. Moderate, they will be having difficulty in recognizing friends and family members and impulsive behavior. However, in severe, they cannot communicate. Behavioral and emotional, and in frontotemporal, there will be some behavioral and emotional difficulty, like difficulty in planning, emotional flatness, and or excessive emotions. Movement problem may be there due to shaky hands, balancing and walking, language problems, they can be there. There are different types of frontotemporal dementia, like there will be behavioral dementia. So we won't go so much in details. The Lewy body can be, there will be cognitive decline in the to concentrate, disorganized. Sometimes there may be illogical thoughts, muscle rigidity, reduced facial expression, sleep disorder can be there, and along with the visual disturbances. Vascular dementia will be there, which is the forgetting of current and the past events, misplacing things, trouble following instructions or learning new things, hallucination, poor judgment can be there. The other symptoms which can be associated may be anxiety, agitation, sleep disturbance, frequent falls, feeding issues, toileting, oral care, dressing, bathing, and infections. As you can see, what people usually see is the memory loss. However, a lot of other things, there is a lot of symptom burden which is inside this I step. There will be behavioral changes, confusion, delusions, which causes a lot of symptom burden in these patients. This staging can also be maybe mild, moderate, or severe. And there can be decline in the cognitive decline, functional decline, and mood and behavioral changes may be there. What are the differential diagnoses can be there? As there is can be pseudo dementia. Pseudo dementia means the causes other than dementia, like the delirium, depression, drug use. Normal aging can also cause dementia, mild cognitive impairment, stress, some brain abnormalities like some hydrocephalus, subdural hematoma, and we should not forget about the HIV, neurosyphilis, and the deficiency of B12 deficiency, folic acid deficiency, thyroid disorder, vitamin E deficiency. So before coming to the conclusion of dementia, we should rule out all these causes of pseudo dementia. So for the how to evaluate this dementia, actually speaking, routine 30-minute visit is not at all enough for diagnosing dementia. It includes the history taking, physical and the neurological examination, and ancillary testing, usually to rule out the cause of pseudo dementia and the dementia. Onset, maybe the history, we should rule out whether it is acute, subacute, or insidious in onset. What was the course of disease? Any past history like hypertension, as vascular dementia is more common in hypertension and diabetes. Any drug history, family history. Family history can be there in the if there is some genetic mutation, as I told earlier, like presenilin can be there. Psychosocial history should be taken in account, and physical neurological examination, like if there are pyramidal and extrapyramidal signs, fasciculations, any gait impairment, and mental status, and common tests like MMSC can be used. For testing and all, as I told earlier, to thyroid function test should be done, B12 should be examined, CBC, CMP, like complete metabolic panel should be examined, and methyl malonic acid folate. And genetic testing, genetic testing should be done for apolipoprotein E, epsilon 4 allele, PET CT, SPECT, CSF analysis, and biopsy can be brain biopsy. However, in alive patients we cannot do, but post-mortem we can do. So this one is the diagram which shows the first one. It is the FDG PET CT of a patient with Alzheimer's disease, and you can see here the hypometabolic metabolism in the cingulate gyrus as well in the parietal region. You can see the lower one, which is here. You can see there is a hypometabolism area. This is because of the right middle cerebral artery territory. How to assess this symptom? The symptom assessment will help in planning the management. That for the daily function, including the feeding, bathing, dressing, mobility, toileting, continence, and the ability to manage finances. Cognitive status, using a reliable and valid instrument like MMSC. Other medical conditions should be taken care of. Behavioral, psychotic symptoms or depression, we should look for all these cases to manage these symptoms as well. And we should always assess the patient decision-making capacity, whether a surrogate has been identified. Caregiver needs and risks should be assessed and reassessed on a regular basis. We should always consider the patients and families' culture, values, language, literacy level, and decision-making process. These are the tools for assessment, like clinical dementia rating, FAST, Addenbrooke's cognitive examination 3, global deterioration scale, neuropsychiatry inventory, and the pain assessment in advanced dementia scale. So this CRS, in which there are 6 items are there: memory, orientation, judgment and problem solving, community affairs, home and hobbies, and personal care. It starts from 0 to 3. 0 is there is no memory loss. Patient will be fully oriented and he will be able to solve all his business and all. Community affairs, he will be doing all the hobbies and all, or fulfilling all hobbies. However, the 3 is the severe one, where there will be severe memory loss, oriented to person only, and he is unable to make any judgment or solve problems. As the score increases, the severity increases. The second one is the Alzheimer's phenotype. In this, there are 1 to 7. From the 7 is the severe grade of dementia. However, the 1 is the patient will be almost normal. Now, this is this is one more, and in this also there are 5 categories regarding the attention, memory, fluency, language, and the visual spatial. The attention, the question will be asked regarding date, season, and current location. And there will be serial subtraction. It consists of 18 points. Memory, there will be past memory will be asked from the patient. Fluency, they will be asked to they will be asked to name animals, what they think of. Language, there are in the language they will be asked to complete a set of sequential physical commands using a pencil and paper. Also, there are 12 line drawings, which consists of a book, candle, and they will be asked to read those things and all. Visual spatial, there will be fragmented 4 letters. There will be dots also, and which we will tell the patients to count. The global deterioration state is having the 7 stages. Stage 1, 2, and 3, there will be no dementia. However, stage 4 is mild one. Stage 5 is moderate. 6 is moderately severe. In this stage 6 itself, there will be diurnal rhythm will be disturbed in stage 6. In stage 7 is the severe dementia. This MMSE is a simple test which also like that only it will consider registration, attention, recall, and language. There are different, and we will tell patients to copy all these sizes to determine whether the patient is having a severe dementia or not. This one is the neuropsychiatry inventory. This is actually the 12 symptom based questions, and these questions are asked from caregivers whether the patient is agitated or not, depression or not, and they will have to write what is the severity and how much it is causing the distress to a patient's caregiver. Management of dementia is not an easy. It requires a multidisciplinary team approach. It requires a neurologist, palliative care physicians, the caregivers, social worker, nutritionist, rehabilitation, occupational therapist or physiotherapist, general physician, geriatrician, and the neuropsychiatrist, and the specialist nurse. What are the cognitive symptoms? Cognitive impairment is the core feature of dementia. The management is mostly the non-pharmacological, and if it's not managed with non-pharmacological management, we can use the pharmacotherapy. These are the different non-pharmacological management, like cognitive or emotion-oriented interventions, like reminiscence therapy. In this, the patient will be asked to remember those happy moments of their life so that they can feel better. Stimulated presence therapy is there. We will use when if the patient's caregiver with whom the patient is so much attached is not there, we can show him or her the video of his or her caregiver, or we can tell them to have some audio of the patient's caregiver if the patient's caregiver is not there. Validation therapy means like we are empathetically taking care of patients, and we are telling them, okay, I can understand that you are not able to remember all these things. Empathizing patient is very much important in this case. Sensitive stimulation interventions like acupuncture. It has been found like in vascular dementia, acupuncture therapy has been they have some role in the vascular dementia. Aromatherapy, like some essential oils or aromatic oils can be used. Light therapy has a role as in dementia. There is a much role of there is altered circadian rhythm. So light therapy can be used in this case. Massage and touch have also been found in dementia. Music therapy has also a role in dementia. Why? Because it has been found that even though patients are aphasic, they are not able to tell anything, but they can actually sing those old songs which are there in their back memory, in their past memory. So music therapy can be beneficial in these patients. Nozzle and multisensory stimulation, it is actually the mix of acupuncture, aromatherapy, light therapy, music therapy. All this combination therapy can be used in this. TENS has also been found, though not much of importance. In pain, it has a much role, but it has been found some benefit in dementia as well. Calendar, like we can make a memory calendar for these patients or normal calendar itself so that they can remember at least the dates and events. Behavioral management therapy have a very much role in this dementia. We can give token economics to patients. Like we give to small children, like if you will do something like this, I will give you this as a reward. So this can help in forming a good habits to the patients. Progressive muscle relaxation was the communication training, behavioral and cognitive therapy can help in at least decreasing the symptom burden in patients. Animal assisted therapy has also been found in decreasing the aggression in these patients. Some like one study, you can go through this article which I have cited. They have told like some robotic pets can be used as a psychosocial interventions in these patients. Pharmacotherapy like donepezil, 5 to 10 milligram OD, rivastigmine. We can start with 1.5 to 6 milligram BD we can start, and 3 to 12 milligram per day we can give. Galantamine can be given in 8 to 24 milligram per day, and memantine, which is an NMDA receptor antagonist, can be used, can also be used in these patients. And how to approach to a patient with agitation? Like we should always look for assess the risk or harm, whether the patient is not doing any harm to others or to self, and ensure adequate caregiver support. So if we think that there is severe risk or harm, we can give the short-term drug treatment by evaluating and treating the underlying cause. Can consider for hospitalization in this patient. If there is no harm, then first we should identify the cause. Whether it is due to delirium, then we should look for the cause of delirium, like whether there is any medical illness which is causing this delirium or any metabolic derangement, or whether it is due to any side effects of medications or due to pain, because pain is mostly unrecognized in this patient. So we should look for any facial expression, any body language in these patients. Depression and anxiety can also cause delirium, and we should consider for a trial of SSRIs or psychotherapy. We should look for the sleep-wake cycle, as this is more common in this patient and which can lead to agitation. Sensory deficits like these are mostly the elderly patients, so they may have some poor vision or hearing problem can be there, and due to this they are unable to communicate. So we should look for all this first we should look for all those symptoms or all those things which we are reversible. If there are persistent symptoms and they are causing the significant distress, then only we should look for any drug treatment and along with the psychosocial interventions. And if there is no any risk factors, we can go for communication skills. And as I told before, the what and all are the non-pharmacological management we can do for patients. The agitation can be acute or it can be chronic. If it is acute, we can same thing. We can go for pharmacological and the non-pharmacological approaches. Pharmacological includes neuroleptics like haloperidol, atypical antipsychotics, benzodiazepine, and acetylcholine esterase inhibitors like donepezil. And non-pharmacological management, already I have discussed before. If it is chronic, then there may be mostly 4 conditions can be there. Like Alzheimer's disease, if it is there, we can look for SSRIs, atypical antipsychotics, or metazapine can be given. If it is due to the Parkinson's disease, we can give the acetylcholine esterase inhibitors or antipsychotics can be considered. If it is frontotemporal dementia, trazodone, SSRIs, and antipsychotics can be given. It is vascular, SSRIs and atypical antipsychotics should be considered. Depression is also very much common in these patients. So we can give SSRIs. We have options of escitalopram, which can be given 5 milligram, per day to a maximum of 20 milligram per day. Citalopram, we can start with 10 milligram to a maximum of 20 milligram per day. Sertraline, we can start with 12.5 to 25 milligram every morning and can go up to 200 milligram per day. Fluoxetine, starting with low dose of 5 to 10 milligram every morning, can go up to 60 milligram. SNRIs, we have options of venlafaxine, which can start with 37.5 milligram once daily to a maximum of 225 milligram once daily. And we have 2 options like extended release and the immediate release, and we can choose accordingly. Desvenlafaxine, we can start with 50 milligram every morning to a we can start with 50 milligram per day morning. Duloxetine, we can start with 10 to 20 milligram per day to a maximum of 60 milligram per day. Atypical antipsychotics like metazapine, we can start with 7.5 milligram HS to a maximum of 60 milligram HS. Propion, we can start with 75 milligram morning dose to a maximum of 150 milligram, and 150 milligram we can divide like morning and evening doses. The vilazodone we can start with 10 milligram once daily. TCAs like nortriptyline, we can start with 10 milligram every evening to a maximum of 100 milligram HS. Desipramine, we can start with 10 milligram morning dose to a maximum of 150 milligram per day. If the patient is having severe anxiety, we can give metazapine and can start with 5 milligram HS to a maximum of 60 milligram. And trazodone, we can start with 12.5 to 25. Always consider that antidepressant effect. For antidepressant effect, we need to have a higher dose of trazodone. So we should always consider whether we are giving as an anti-anxiety or as an antidepressant. uh, it is very important to distinguish between delirium and dementia. So around 22% of the older adults, they have with dementia, they develop delirium. So management includes the clozapine, 25 milligram we can start. Other options are haloperidol, melperidone, piperone, and quetiapine and risperidone. So this is the difference between delirium and dementia. Usually the delirium will be acute while the dementia is insidious in onset. Mostly the patient delirium, the patient will be usually tachycardic or they have fever. Usually in dementia, it is normal. Course is usually in dementia, in delirium, it is rapid, and dementia, it is progressive. Short duration in delirium and long in dementia. Consciousness is usually altered in delirium, while it is clear in dementia. Attention is impaired, attention, alertness, all these agitated behavior, these are impaired in dementia. However, it is intact in dementia. Sleep problems are also very much common in this, so there should be personalized. We should always make a sleep problem is very much common in this. So the sleep hygiene should be maintained. Exposure to daylight, exercise, personalized activities should be done for these patients. And falls are very much common, so we should always find out the myelopathy, like B12 deficiency, neuropathy, and visual impairment. Pain is common in around 50% of the patients, and however, it is difficult to assess. Challenges is there for the patients with dementia, loved ones, even for the health professionals and society. This is the pain score, and this one is the score for the assessment of pain in the dementia, and it consists of 5 observations like breathing, any negative vocalization, facial expression, body language, and consolability. And the score is from 0 to 2. 0 is the normal, and while 2 is the most severe symptoms. Management of pain in dementia. Firstly, we should look for the non-pharmacological management like music therapy, any movement therapy, massage, touch, heat, and relaxation therapies, and human interaction and presence. Pharmacological management, paracetamol is the safe for these patients, and it is the drug of choice for these patients. NSAIDs is usually associated with increased risk of adverse effects, so it should be avoided. However, there is no study which has investigated the risk and benefit of short-term use of NSAIDs for treating moderate to severe pain. Oxycodone and morphine, they don't have much, we don't have much evidence to say that whether it has any role in dementia or not. And no clinical trials have been investigated the safety and efficacy of adjuvant analgesics like antidepressant and anti-epileptic drugs. Dysphagia and weight loss are very much common in these patients, and it is also bothering for the patient, their caregivers, and the family members. What are the nutritional tips for these patients? There should be balanced diet, and the food should be high saturated fat, and cholesterol should be there. We should cut down the refined sugar, limits the food with high sodium and use of less salt. The meal time should be comfortable. We should limit the distractions, and we should check the food temperature, flexible with the food preferences, allow plenty of time to eat and eat together. And we should always encourage the independence and make the most of the person's ability. Serve finger foods, try hand over hand eating, and we should not worry about the neatness. And the prepared food, they should not be hard, it should be soft, and we should look for the signs of choking. And there is always a debate between whether we should give the oral food or versus the tube feeding. And there is no obvious difference between the longevity of patients, whether the patient are tube fed or the careful hand feeding. We should always emphasize on careful hand feeding, which offers the highest quality of care. As the tube, it leads to tube dislodgement, blockage, and leakage, which leads to more hospital visits. It is always ethically permissible to withhold nutrition and hydration artificially administered by vein or gastric tube in end stage of life, who are unable to receive food or water by mouth. It also endorses the use of advanced directives. And always, so many times we see that the patients are on antibiotics in the suspected infections. So most of the times it is inappropriate and often started without adequate clinical evidence of an infection. So the clinician should have minimal criteria to suspect infections and also to start the antibiotics. So this one is the minimum criteria for starting antibiotics in these patients. If there is suspected urinary tract infections, like if we are seeing that there is indwelling catheter, temperature is more than 37.9, or any new onset, any urgency, or if there is indwelling Foley's catheter with rigors and change in mental status. If there is suspected respiratory tract infection, like temperature more than 38.9, or if the respiratory rate is more than 25, any new productive cough, or if there is a change in the mental status, or even if the patient is afebrile with COPD, if there is increased cough, we should go for antibiotics. And suspected infections like skin infections, like temperature if more than 37.9, redness, and increased swelling and tenderness, or any febrile episode more than 37.9 degrees Celsius. Now, it is very important to take care of personal needs of the patients, like the oral care. We should always look for the oral cleaning and oral care, cleaning the dentures and brushing the patient's gums, tongue, and roof of mouth. Dressing, we should respect the person's dressing style. We should always groom, like nail filing and electric shavers should be used. Always, we should always maintain the personal hygiene by taking care that the patient is taking bath or not at proper interval, and we should never leave the person alone in the bathroom. Wash the most sensitive areas, including his head, face, and perineal area at last. So we should always create a toileting schedule for this patient. Should give sufficient liquids and high fiber diet should be given. And we should assist the patient in walking, balancing, and strengthening aids can be used like walkers. And we should always maintain person's ability to move within a living space. Vision and perceptual changes should be examined and assessed for dehydration. As we know that these patients are having mostly on the polypharmacy, and there are a lot of drugs apart from these drugs which the patients are taking for dementia. So we should throw out all the medications which are out of date and no longer is in use, and avoid the polypharmacy. One more phenomena they most of the time they suffer is the sound dawning phenomena, which is the worsening of neuropsychiatric symptoms in the late afternoon or early evening, and it affects around 2/3 of the patients. There is disturbed, which is mostly due to the disturbed circadian rhythm. This factors includes the poor light exposure and disturbed sleep, which is mediated mostly by the degeneration of suprachiasmatic nucleus of the hypothalamus and decreased production of melatonin. Treatment includes the bright light therapy, melatonin, acetylcholinesterase inhibitors, NMDA antagonists, antipsychotics, and behavioral modification. What are the barriers in the dementia? Administrative and the policy issues, like sometimes there are regulations, access to palliative care, financial reimbursement, advanced directives, staffing shortage, continuity of care, and integration of services. Education includes where we are not enough, sometimes we are not enough able to recognize when to start the palliative care, and it should be started early, and mostly recognition of the terminal stage, and also the lack of knowledge and ethics and awareness of palliative care. Communication is there because the lack of communication with patients or the family members, staff, and personal characteristics like attitudes, beliefs, and values. And these are the trigger factors. Like in mild or early dementia, most of the time of diagnosis, there should be early. If we are finding that any new behavioral symptom change, we should always, it should be a trigger factor for it. And here we can give the advanced care directives by identifying this, and treatment for depression if there is associated depression, and management of cognitive symptoms. And apart from that, caregiver assessment and support should be given. In moderate dementia, we should always screen for and treat the behavioral and psychological symptoms of dementia. Safety evaluation should be done, and caregiver support and referral to the community services should be done, and they should be provided with home and assistant living and nursing. If there is advanced dementia, we should always reassess the goals of care, as goals of care changes with the advancing dementia, and deprescribing the medications. And we should always give only, we should not burden the patients with medications. This is the first, which I have already discussed earlier. These are the criteria for hospice admission. If it is beyond 7, patient is unable to walk, urinary and fecal continence, there is no meaningful verbal communication, or medical conditions like the patient has aspiration pneumonia, pyelonephritis, septicemia, ulcers. These are all are the criteria for referring to the hospice. As the prognostication in dementia is very difficult, because it is less predictable course. If it will be prolonged if there is gradual decline, and maybe the plateauing may be there. But however, in acute illness, there is a sudden downfall in the functional decline. So it is very difficult to prognosticate in dementia. Actually, prognostication helps in guiding the end of life decision making, and it is also a determinant for hospice eligibility. And these are the scales which we use for prognostication. If it is more than 7C, so the median survival is around 3.2 months. And if we can risk the mortality risk index with this, and if the score is 0, the 6 months mortality is 8.9%. However, if it is more than 12, it is around 70%. So this was one study which was published in Sage. However, this is an old one. It was published in 2012, which shows what are the prognostic indication of 6-month mortality in elderly population, and where they have found that nutrition was the most common factor. Those patients who are nutritional status was poor, they had more chance of mortality, 6-month mortality. And this one is however, the caregiver burden. This diagram shows what are the caregiver burdens, as the caregiver also suffer a lot along with the patient. This was the background. If the socioeconomic status is poor, they suffer more, and also this will lead to the work interference, financial strain, family conflict of the caregivers. The stressors include the patient characteristics, like if the cognitive decline is more, it will be causing more stress to the caregivers. And if there will be more hours, so there will be more hours of dedicated hours to the patient's attender will be giving the more dedicated hours to patients. This will lead all this to stress. And so all these things like the loss of work hours, the family conflicts, or this will lead to the psychosocial, physiological health, behavior, and general health. This will lead to stress to the caregivers as well. And this one is the criteria for the stress, how to calculate the stress of the caregivers. So Kingston caregiver stress scale is used to determine the stress in the caregivers, and where there are 10 questions, and from 1 to 5. More is the score, more is the stress in caregivers. This was one article which reviews regarding regarding the supporting caregivers, how we can support the caregivers of people with dementia. And however, they have come with 6 criteria, but they have not come with a proper guidelines. So we can go, this is an area of research where we can go further. Advanced care planning is very important in this patient, so that they can live with dignity till their last stage. And this is a dynamic process of reflection and discussion between patients, relatives, and healthcare professionals, which will allow patients depending on the stage of illness to communicate their values and treatment preferences when they are not able to take the decision. So this was one article which was published in BMC, and they come with 8 domains and 32 recommendations, like how to initiate ACPs, evaluation of mental capacity of patient with dementia, and how to document the wishes and preferences, end-of-life decision-making, and preconditions for optimal implementation. What are the legal aspects in dementia in India? So in 2010, Alzheimer's Related Disease Society of India, they came with Dementia in India report in 2010 and strategy report in 2018. We have got a various government initiatives which supports dementia. like a scheme of integrated program for older persons by Ministry of Social and Justice Empowerment, Department of Empowerment of Persons with Disabilities, such as Rights of Persons with Disabilities Act 2016, and the Ministry of Housing and Urban Affairs. Also, there is a national program for healthcare for elderly, which has taken initiatives to train the healthcare professionals for dementia. There is a Mental Health Care Act in 2017, which also includes the dementia. And Bengaluru, it has been found that around the top 30 global cities in the dementia, there is the Innovation Readiness Index 2020 published by the Alzheimer's Disease International, the Global Coalition on Aging and Line Foundation. What future holds for dementia? It holds for towards a dementia-friendly India by minimizing the risk, awareness raising, early diagnosis, memory clinics, services for those with dementia and their carers, and a robust national dementia plan, and more research, and integrating palliative care at the time of diagnosis. So while going through this, while I was preparing for this seminar, I came across this poem, which has been written by Owen Darnell, which actually states the what a person suffering from dementia feel. So the conclusion is of my seminar is, so dementia is a life-limiting syndrome with uncertainty in the course of the disease in the individual, and challenges to predicting survival after diagnosis and approaching end of life. Interprofessional and interdisciplinary collaboration approach is the need of hour for holistic care of patients as well as their caregivers. The key to effective palliative care is communication, prognostication, and symptom management. By redefining goals of care during the disease trajectory, from control of disease to end of life care, can smoothing this whole journey. So these were my references which I used. Thank you.
Very good, Manisha. It was so comprehensive. Nishkarsh, you want to say anything, and then we can have questions and answer?
Uh, yes, ma'am. So, dementia, as we have discussed today, is a problem which is multidisciplinary. There are many symptoms which need to be addressed and often ignored. The most important thing while dealing with patients of dementia is first we have to find the correct diagnosis. So, delirium, acute delirium, mostly because of electrolyte disturbances, is quite common and is treatable cause. So if we have to really differentiate, and sometimes becomes tricky because patient might have a dementia along with an acute delirium. So the reversible things have to be addressed, and most common being hyponatremia, and because elderly patients, if they don't eat for some time, they tend to develop disturbances, and we need to correct it. Second important thing is, which is often ignored in addition to care of patients, is the caregiver burden, because it is really difficult to manage patients of dementia, in the sense you need somebody with them every time, and they cannot be left alone, especially in advanced stages, and they are dependent on activities of daily living to their caregivers. So that thing is often ignored and need to be addressed uh, carefully. Another important thing is that like any other life limiting disease, it is better we understand the problems and start palliative care for such patients at an early stage, because that becomes more easy, patient become more receptive, and we can always treat the symptoms as they come, because in advanced stages it is often difficult to communicate with these patients, and becomes really tricky to handle them. So we can take questions because we have about 10 minutes. So there is a question: no difference in careful hand feeding versus tube versus feeding last stages. Take home message for me. Okay. Very so.
It was a very good take-home message. Who's is taken this, that there is no difference in tube feeding and hand feeding. I think this was very good, Dr. Harry. You have noticed. Dr. Stanley, you would like to add anything? Stanley, Dr. Stanley. Yes, go ahead. Yeah.
Thank you, Manisha. Very nice, very good coverage. Learned a lot of useful tips. Um, one thing, a couple of things I just want to emphasize based on experience, not from so-called textbooks. One is that a lot of these people, they have lack of memory, but a lot of them have feelings which are very intact, So your presence with them, how you talk to them, how you help them to bring out those emotions, help them to feel valued, and you can combine this with some gentle, simple physio, like as you're talking to them, move all their joints, starting with the thumb, your fingers, your wrist. As you're talking, you can move all those joints. So because this pain of immobility is a very, difficult problem in these patients. And so liberal use of paracetamol, 2-3 times a day, just give it to them, especially one at night, so that they can sometimes sleep better because of that. And that is the thing. And also people approaching, because this can be protracted, the whole thing can go on for years. How do you identify people who are approaching the end of life? And I find the UK, the gold standards framework and the prognostic, what do you call, indication guidance, PIG, it helps, and it is quite simple. And you can discuss it with the geriatrician or the people who are dealing with dementia, and then see what is more relevant for our situation in India and make a little modified chart for that. Because once we do that, then we're able to strengthen the family further. And just to remind you that during our Silver Jubilee IAPC conference in Delhi, we had a combined, what you call a Delhi declaration, where we asked the government, to provide palliative care for all these kind of people, the dementias and also the geriatric group. So thank you very much.
Thank you, sir. Thank you for the comment.
Anyone?
Thank you, sir.
So, Manisha, there are a lot of compliments, huh? And I think you have given a lot of good overview today, that how to prognosticate, how to assess pain, how to take care of caregivers, and how to assess the caregiver burden. What are the various aspects which we can take care? I think it was a very comprehensive seminar. Anyone wants to have any other comments? Otherwise, I just want to say one thing, that all the residents, those who are listening this class, and their teachers, it is going to be always tough to integrate palliative care in a patient with dementia. So from today onwards, you should definitely reach out to your neurologist and ask them that there is something called integration of palliative care in a patient with dementia, and we want to help your patient. So today only you should go and talk to them. And in early stage, definitely they may not refer to you, but in definitely there are so many things which you can help them. And one thing which definitely we can help, introducing advanced care planning in such patients in your hospitals. I think this is very, very important. And IAPC is coming out with this proposal, that how to help all the patients, those who needs advanced care planning. But till the time, I think today onwards, all the patients, those who are requiring your care in neurology ward, I think you will have to approach. It's not going to be easy. Neurology will not allow you to, they will think that they are just end of life care people if they are not understanding you well. But definitely there are so many things which we can do, and we have seen with symptom burden, it's not only that memory loss or something, but there are such a high symptom burden. We can help them, and we can help them by introducing advanced care planning. Otherwise, all these patients ultimately will end up in ICU. And you have seen in our neurology ward, so many times we keep struggling with these patients. They put them on ventilator. So they are going to be in ICU unnecessarily. So this is right time that today you have heard everything about dementia. And from today onwards, you should start approaching your neurologist, that there is very significant difference we can make in quality of life of your patient in dementia. Anything, we have 6 more minutes, Nishkarsh, just to conclude. Or
Yes, ma'am. So, most important problem in these patients will be that they don't admit. So, the caregivers will not admit, patients will not admit, and they don't come in time. So, they usually end up in a later stage when it is really difficult to manage them, because we don't have a time to make a repo. You cannot make them understand, and the caregivers are mostly in denial, because dementia is like a stigma. No, they tend to make fun of people who have dementia, so it becomes really tricky in this sense. So, ma'am, you are absolutely right. So, we need to talk to our neurologist and geriatricians who are managing these patients, and it's high time that we start integrating, providing good palliative care to these patients at an early stage when they come. We do a mandatory screening and then try to help them out through their journey when they are managing dementia at home, both for the caregivers and for the patients.
so this we have to take the initiative. Nobody will take the initiative
Yes, ma'am.
because nobody knows about this. So all the residents and their departmental faculty, those who are listening this lecture, I think they should take this initiative. Anyone
So,
wants to add anything? We have 1 to 2 3 minutes.
so there is one question from Dr. Parvesh. He's asking about Ayurvedic preparation for dementia.
We don't know.
We don't know, to be honest. So, whatever helps them, they can take, but we don't have a clear answer that this will help or not.
Okay, if there are no comments, we can stop here. Thank you very much, Manisha and Nishkash.
Thank you, ma'am.
Thank
And
you, ma'am.
thank you, Archana and Nisha. We'll see you all next week before 6:30, next week, Monday.
Thank
Have
you,
a
ma'am.
nice. Thank
Thank
you.
you.